Welcome back to RhAPPcast, the official podcast of rheumatology advanced practice providers. I'm your host, Amanda Mixon, president of RhAPP, and today we're going to dive into a topic that's often underrecognized yet critically important: hypophosphatasia, or HPP, in the pediatric population. This episode, Born with Burden, Understanding the Pediatric Presentation of HPP, explores how perinatal, infantile, and childhood-onset HPP can present, why it's so frequently missed, and the profound lifelong impact early symptoms can have when they go unrecognized. Pediatric presentations of rare diseases can be subtle, complex, and easy to overlook, and our goal today is to shed light on the key clinical clues and unique burden faced by children and their families. I'm so excited to have someone who brings exceptional insight to this discussion, RhAPP board member and pediatric specialist, Brandon Coe. Brandon, thanks so much for being here. Can you just give a brief introduction to our listeners?
Yeah, hi, Amanda. Thanks for having me. I'm happy to be here to talk about this fascinating topic. I've been a pediatric nurse practitioner for the past 15 years, and then helping to run the University of New Mexico Pediatric Rheumatology Clinic for the past about 8.5 years. I'm also the pediatric chair of the RhAPP Board of Directors. I love any opportunity to get education out to our members especially about rare conditions like hypophosphatasia that can be a challenge in the rheumatology setting to differentiate from some of our other conditions.
It's so true. And, again, I learned so much from you. And it's just invaluable. I feel like as an adult rheumatology provider, oftentimes, we don't really learn about, the things that impact children because we see them again when they're adults. But it's so important that we recognize these things because a lot of these things carry over. So I think this is really going to be a wonderful episode for not only our listeners, but me personally, because I'm sure I'm going to learn a ton. So to start us off, can you please walk us through the different forms of pediatric onset HPP, perinatal, infantile, and childhood, and what distinguishes their early clinical presentation?
Yeah, I'd be happy to. And I echo that sentiment about kind of the cross-pollination of knowledge between peds and adults, because as you'll see in this discussion, there's some features of adult diseases that cross over into pediatrics that we're really not familiar with either. And so kind of this collaboration is always kind of really informative. And pediatric hypophosphatasia, or HPP, is something that I wasn't really aware of, was not part of my training as either a primary care peds nurse practitioner or even really on the radar as a peds rheumatology provider. And so something I've learned about along the way. And I think that might be a familiar scenario for a lot of people. So, which is why I think it's important to raise some awareness for this condition. As we'll see, it can mimic several of our rheumatology conditions, in particular pediatrics, things like juvenile idiopathic arthritis or JIA, and then could also potentially raise concern for things like Sjogren's disease, leads you down the wrong path there, or pain amplification syndrome, which in pediatrics is kind of our version of fibromyalgia. And so pediatric hypophosphatasia, or HPP, is a rare inherited metabolic disorder, and it's caused by a loss of function mutation in the ALPL gene. And this results in a deficient activity of tissue nonspecific alkaline phosphatase, or TNSALP. And this kind of loss of function causes impaired bone and tooth mineralization. And these will be kind of the hallmarks of this disease, but the way they present can be very subtle. It's actually been said this has some of the greatest clinical variability of all the skeletal diseases. And so, again, lots of different ways that this can show up in the clinic. So the pediatric onset for HPP has 5 forms, and they go from very mild or limited to very severe. And so kind of the most limited form is called odontohypophosphatasia, and this is isolated just to the dental manifestations. So this impaired tooth mineralization, it is characterized by premature loss of deciduous teeth. From there, you can have a mild form of childhood onset HPP. And this is kind of dental problems and some mild skeletal involvement, with osteopenia and things like that. The severe childhood form of HPP has significant skeletal disease. And you start to see things like rickets, short stature, bowed legs, and motor impairment. as we go further on in severity, and then you think of earlier onset with more severe presentations, if an infantile HPP presentation is happening, you can have a more life-threatening presentation. This has severe skeletal hypermineralization. You end up with respiratory problems, failure to thrive. And these infants can sometimes develop pretty severe hypercalcemia and paroxetine-dependent seizures. And so, and then the last and most and probably rarest form of HPP is perinatal HPP. So things actually happening during the pregnancy, profound skeletal hypomineralization, and this unfortunately is often lethal.
I mean, it sounds like obviously if someone is on the more severe side, it would be a little bit easier to identify. But some of those more mild ones, I feel like, it really could potentially, be missed if you're not, if you don't have these clues to know what to look for. So what are the earliest clues in newborns and infants that might signal HPP, even maybe before more obvious symptoms emerge?
Yeah, it can be really subtle, especially for these intermediate forms of HPP. And so the things that can kind of lead you in that direction and put this on the radar as far as your differential would be things like impaired motor skill development, not meeting milestones. And then for young kids, infants, and babies, think of things like unexplained causes of failure to thrive, and then some instances like craniosynostosis, or that kind of fusion of those cranial sutures. They can sometimes cause plagiocephaly and things like that. So those would be kind of the earlier childhood things, the infantile things. There's a couple of other things in childhood onset that we can talk about.
Yeah, so let's talk about that. So what about in childhood onset disease? What subtle signs or patterns should rheumatology providers be paying close attention to that are commonly maybe overlooked or misattributed? Because it's super, super interesting.
Mm-hmm. And yeah, as kids get older, you start watching for these patterns of impaired bone mineralization that can cause this kind of diffuse musculoskeletal pain. And so again, these are going to be things that are picked up probably incidentally during an evaluation. So you have kind of a non-specific musculoskeletal pain, and we see this quite often in pediatric rheumatologists referrals. And then sometimes you'll have like radiographs that are checking for, are we seeing arthritis? Are we seeing fractures? Are we seeing things like bone lesions or concerns for malignancies or things like that? And a pattern of impaired mineralization or osteopenia without a better cause could be a clue to look for something like HPP. Another big clue would be this premature loss of deciduous teeth, or kind of baby teeth. If those are falling out faster or sooner than you'd expect, that is suggestive of impaired mineralization of the teeth and would lead one down the road to look for something like HPP.
Yeah, I mean, it sounds like it can definitely be missed or potentially misdiagnosed. So from your personal experience, what are the most common reasons for this delayed recognition in the pediatric patients?
So I really think it's lack of awareness. Like I said, I had not heard about this condition until kind of well into my pediatric rheumatology career. And it can be subtle and it is fairly rare. And so it's one of those things I think is easy to fly under the radar because the presentation can mimic so many other things, as far as this kind of non-specific musculoskeletal pain and things like that. The patients will often present with joint pain, and that would be what would cause them to come into the rheumatology clinic. And so you have episodes of peripheral joint pain in the majority of patients. But you can also see axial pain, caused from like spinal stenosis or osteoarthritis of the spine. And then long bone pain would be something that would be kind of unusual for our rheumatology presentations, and would lead us down the road for looking to other differentials. We think about things like cancers, stuff like that. Sometimes things like growing pains. But also HPP, is something that should be on that differential too. And there's an interesting overlap with psoriatic arthritis that we'll talk about a little bit later. But I think the key kind of unifying factor of all of this is that this is a kind of a metabolic issue. And so at HPP, there are these three substrates that accumulate that can cause the problems with mineralization. This is something called inorganic pyrophosphate, or PPI, pyridoxal 5' phosphate, or PLP, and a phosphoethylamine, or PEA. And these are the things that actually are going to be the next step in evaluating for HPP that we'll see here. But it's important to know that these are the underlying kind of causes of some of this impaired mineralization, especially this thing called PPI. It's a potent mineralization inhibitor. But the key thing to test for, if you're worried about this, or if any of these unusual kind of patterns are popping up, especially with this loss of deciduous teeth, is to check an alkaline phosphatase on ALP level in any pediatric patient with unexplained musculoskeletal pain, especially when accompanied by something like early onset arthropathy, premature tooth loss, or this family history is really key of dental and skeletal problems. And that's available in kind of a CMP that we often routinely draw for other things. So just making sure you're paying extra attention to that alk phos, which often I feel like flies under the radar, especially in pediatrics, where it is often high in fluctuating levels for all kinds of reasons. Especially growing kids have fluctuating levels of alk phos all the time, but low alk phos, especially persistently low alk phos, should raise concern for HPP.
It's interesting because in the adult world, I was doing another podcast talking about this in terms of like kids that, get missed. And then, we see them as adults. And I just think to myself, how many times have I kind of ignored the low alk phos level, just thinking, oh, it's a fluke or, something like that. And really, it's so, so important for us to just understand that if something's out of the realm, particularly like ongoing, you really should look into it and it should raise your clinical suspicion, particularly, just asking the right questions. And I have to be completely honest, prior to doing the research for, this podcast series, I don't know that I was asking the right questions. And so, it's just so important, I think, that we recognize this and understand. So when you're evaluating a child with bone pain, fractures, or kind of these unexplained musculoskeletal symptoms, what elements of the history or exam can help you differentiate HPP from more common pediatric conditions?
Yeah, that's a great question because as you can see, they can be subtle at very least kind of like general or non-specific presentations for things. So the big red flags that would warrant kind of focusing on that alk phos and considering something like hypophosphatasia would be, again, this unexplained musculoskeletal pain, especially in the setting of normal inflammatory markers, especially in the setting of without clear signs of something like arthritis or JIA. Like these kids are not typically going to have the same kind of like pattern of swollen joints and things like that. It's more this musculoskeletal pain, this bone or joint pain. Inflammatory markers should be normal, and exam is relatively underwhelming as well. So the history is really kind of key, and then taking that next step to watch for, pay attention to the alk phos, and then take further steps to trend it, and then check in for other biomarkers if concerned. One of the other big things that comes up in the literature about HPP is early onset calcium pyrophosphate deposition disease. Now, this probably sounds more familiar, Amanda, to you than to me, right? With this kind of crystalline kind of arthropathy, we don't really see this in pediatrics. So if you were to see this, you do a joint aspiration and crystalline, you find crystals on the synovial fluid, and it comes back with CPPD disease, CPP disease. Like that would be a big red flag to think like, wait, this is unusual for pediatrics. Why is this patient having crystalline disease? This is, a red flag for any patient under 50 years of age. So squarely within the pediatric range. If we were to have a kid that has this is unusual. And that would definitely be something you'd want to check for HPP and that alk phos, look a little bit sooner. Again, that premature loss of deciduous teeth is a big red flag. It should always kind of warrant evaluation for alkaline phosphatase. Family history of dental problems or like weak bones in the family with early fractures and things like that, or recurrent fractures. And then for a patient to have kind of fractures with either minimal trauma or recurrent fractures should also raise concern for something like a mineralization disease like HPP.
I think even as the adult, room providers that are listening, or primary care, because we have some primary care folks that also listen to the podcast, you shouldn't really see CPPD in younger people, like younger, patients. Like, so I kind of think because we think of that as being like, I don't know, something that older people get. So again, if you are seeing that on x-ray, or some features of that, again, that would be another, I think, red flag for the adult folks to say, something's not right here. I better make sure there's not some kind of underlying metabolic bone disease, that, could be contributing. So what do you feel like is the greatest unmet need in improving early identification of pediatric HPP within rheumatology and primary care?
I think it's really awareness. And so
Mhm.
I'm glad we're doing this podcast, kind of getting this information out there. So like I said, it is not a common diagnosis. There's a lot of subtle findings that go into it. If you don't know what you're looking for, it's really easy to miss. And that's underscored by the fact that in the literature, the median diagnostic delay is 13 years. And so, especially for the intermediate forms, like you had said, it's important for our adult colleagues to recognize this as well, because we might miss this in pediatrics, and these kids, or they might present a little bit later, and kind of that diagnostic evaluation stretches into their early adulthood. And so having this on the radar is super important, and maintaining kind of a high clinical suspicion. And so again, for that early onset CPPD, like you had said, about 71% of HPP patients present to rheumatology clinic with this finding. It's funny you say kind of your older patients. In my world, all of your patients are older patients. That premature loss of primary teeth. And, this is something I feel like for either older kids or young adults and things like that is going to be something that really they have to rack their brains out. They're like, oh, how old was I when I lost my baby teeth? They're kind of talking to their parents or kind of having them kind of, basically kind of look into that themselves to help you figure that out. But for our pediatric patients, this is a part of the both the diagnostic criterion and occurs in about 64% of pediatric patients with HPP. And then again, those patterns in musculoskeletal pain are really important, especially without a better explanation for them. The majority of patients present with peripheral joint pain. 86% of patients in the rheumatology clinic that end up having HPP present with peripheral joint pain. But that long bone pain is also a feature of that bone pain. We think of these kids more of like possibly CNO patients or things like that, which would be another mimic. And then, JIA is typically localized to the joint, similar to like RA and things like that. But for HPP, you can have more of this long bone pain. And then axial disease. And so the osteoarthritis or spinal stenosis from that kind of bony, metabolic bone disease can mimic things like spondyloarthritis and things like that. And as far as like in my world, and probably you guys as well, we're thinking about dental health and stuff. The first thing that jumps to my mind is not HPP, it's Sjogren's, right? And so, in Sjogren's, patients often have kind of arthralgias, diffuse arthralgias in addition, that are maybe a little bit harder to localize. And so, if I feel like if I have a Sjogren, if I have a concern about a patient with recurrent dental issues like early tooth loss and stuff like that, or dental decay, and then bone pain or polyarthralgias or joint pain, but the labs are not suggestive of Sjogren's, having HPP on the differential can be helpful as well. But HPP is not the only thing that can cause low alkaline phosphatase either. And so before attributing a low alk phos to HPP, you also have to think about some of the other things that can kind of cause this, and can sometimes overlap with some of our conditions as well. So there's some nutritional and metabolic causes of low alk phos. And so you have to think about malnutrition or calorie depletion. And so the history is really important in taking that overall picture in is this kid having some kind of specific dietary restrictions? That is, there's anorexia going on? Is there some kind of restrictive eating patterns or something like that? And then specifically, like zinc deficiency is a classic cause of low alkaline phosphatase. Hypothyroidism, something to consider as well, and can cause low alkaline phosphatase, as in celiac disease. And so again, with that, autoimmune conditions like to travel together. And so I have several patients who have overlapping peds rheumatologic conditions with autoimmune thyroid disease or celiac disease or things like that. And so an evaluation for those is really important as you go down this road of low alkaline phosphatase and working kids up for HPP.
That's super helpful to, again, know what other things we should be checking for too. I learned the other day that also Wilson's disease can cause a low ALK phos. So thinking about that too.
That's a really important
control. Yeah, just to kind of think about like putting our thinking caps on, like it's not normal. So like we should be doing some of these other workups. That's super, super helpful. So for clinicians who may not frequently encounter pediatric metabolic bone disorders, I know I don't really as an adult rheumatology provider, what practical steps can help build awareness and, confidence in recognizing potential HPP?
Yeah. So a good kind of stepwise approach to this. If you're worried about a patient who has low alkaline phosphatase, so you want to obtain that medical history, right? And so going over all of those historical things about the tooth loss, the family history of weak bones or early tooth loss, any history of easy trauma or like easy fractures, things like that. You're going to want to repeat that alk phos, right? Because one low does not mean, does not seal the diagnosis. You have to confirm that there is kind of a persistent, a low alkaline phosphatase to be worried about some HPP, because it should not really be fluctuating low one day, high the normal, or high the next, and then low again. It is a persistent deficiency of alkaline phosphatase. So after an initial low measurement, you're going to want to wait 2 to 4 weeks and then repeat to confirm the persistent low alkaline phosphatase. And then screening for any of those kind of other contributors to it. So things like hypothyroidism, celiac disease, Wilson's disease, malnutrition, things like that. But then if that alkaline phosphatase remains persistently low, then you should be looking more and more into HPP and being kind of proactive with that evaluation to make sure we don't miss this rare condition. That HPP specific testing for that would be that plasma PLP, a urinary PEA, and then if those things are concerning, there is specific genetic testing for alkaline phosphatase, and specific therapy for it as well. I think the main kind of point of this podcast is to try to raise that awareness about what to be looking for. And then kind of this, so you can refer back to the literature for the steps in evaluation from there. So do not feel like you have to memorize those kind of metabolic, like downstream effects for things. Those are things that, if you're looking for like what are the next steps for evaluation of HPP, that's a readily available information to go back and find for it's that main low persistent alkaline phosphatase that should be triggering that further work.
Well, I think if you are someone that is seeing this and want to know, I know a lot of the commercial labs have this available so that you can, contact your lab and find out how specifically to order the testing, because full transparency, I've not done it yet, but I think I now will, now that I know about this, and probably, have missed this because I wasn't looking, and so, thank you so, so much, Brandon, because I feel like I always learn a lot from you, and you sharing your expertise and really helping us better understand how the early and often overlooked presentation of HPP in children can present. Your insights into perinatal, infantile, and childhood onset disease truly highlight why awareness and early recognition matters so deeply, not just for the diagnosis, but for lifelong impact that it has on the patient. And I would also say the patient's family, because I bet, if the family members, obviously it's genetics. So I would bet if we were able to make this diagnosis, we could also potentially change the lives of these patients' families. To our listeners, thank you so much for joining us for this important conversation. We hope today's discussion equips you with new perspectives and practical clues to bring into your clinical practice. Remember, please, all of RhAPP's digital education, including our podcast, short form media, and our broader curriculum, is housed in the content room on rhAPP.org and on the RhAPP ACE 2.0 mobile app, and on your YouTube channel with audio episodes, also available on all major podcast platforms. So wherever you are learning, we are there. If you enjoyed this episode, please subscribe, leave a review, and share it with colleagues who you think could benefit from this. RhAPPcast is proud to provide high-quality, disease state-focused education to the rheumatology community, and your engagement helps us continue that mission. Again, Brandon, you're just so amazing. I respect you so, so much. So thank you. And thank you for being such a wonderful board member too.
Thanks again. Happy to be here.
Until next time, this is Amanda Mixon and you're listening to RhAPPcast. Take care and we'll see you in the next episode.